So we're going to talk about valve in valve, and I put my timer on to try and finish up in 10 minutes time. So we understand that, yeah, this is very clear. It totally depends. Valve degeneration depends upon the age of operation. That's been seen. The earlier the operation in life, the greater is the valve degeneration and that happens earlier as well. It's clearly which is an accepted. The FDA accepts it as an alternative for a resurgical valve operation. So valve in valve is as long as a heart team surgery is going to be a higher risk. So this is an acceptable situation. This is the one of the hot off the press. This is from Canada. They looked at early and late outcomes on a propensity match cohort. Very nicely done in JACC cardiovascular intervention, looking at valve in valve versus redo surgery. And clearly, if the 30-day mortality was significantly decreased, the new pacemaker implantation was lower. Blood transfusions obviously would be lower in valve procedures, and the 30-day readmission rates were not different. And of course, this is what the graphs show. This is, of course, the survival probability, which was better with TAVR valve in valve versus surgery, redo surgery. This is the all-cause readmission cumulative incidence, which was not significantly different. And this was freedom from MACE, which was significant, which was not significantly lower. But you saw that the survival probability was certainly higher with valve in valve. So that's very reassuring as far as this is concerned. We understand that there's an increasing list of bioprosthetic valves, stented and stentless, bovine and porcine pericardiums. And a variety continues to increase, obviously. So considerable knowledge around this is absolutely essential when we go for a valve in valve procedure. We need to understand also that we have to ascertain the hemodynamics. We need to rule out a patient prosthesis mismatch when we implant the next valve. We need to understand the implant label, sizing. And there's an issue about all this because really there's no standardization of valve size labeling of a surgical valve across the industry. It's so very much important because the label valve size corresponds to the outer base of the diameter ring. And that typically determines the maximum valve size. But it has got very little to do with the internal valve size because the same size of a valve from a different companies could actually have a different internal diameter. We need to understand that the true ID is what we need for implanting a transcatheter valve, and that is what we always look at. So for example, a porcine leaflet mounted inside could actually be the true ID could be 2 millimeter less. And if it's a pericardial leaflet, which is thinner and mounted on the inside, it could be 1 millimeter less, the internal ID. And for a pericardial leaflet mounted outside, of course, the stent ID is actually the true ID. So again, we have these issues that we have to understand. Of course, much of our life has been made simpler by Vinny Bapat's app. I want to discuss with you every every structural heart specialist understands this app and takes it through. And this has made life so much simpler and in many ways idiot-proof for us in terms of deciding the size of different types of valve in relationship to the surgical valve implanted. So we want to understand, of course, there are a number of slides here which I just want to skip through primarily because I didn't have time to put the slides together, but just emphasize on some of the very important points. We have these fluoroscopic appearances of the heart valves. Are a variety of them, and some can't be even seen, so there are non-radiopaque valves as well. The important aspect of understanding this is, luckily, Vinny Bapat's app shows you the radiographic appearances of the valve as well. What is important is that to understand the complications associated with it. Of course, these are the most important dreaded complication is the coronary ostial occlusion with these, and we'll just address that rapidly. We have, of course, the malpositioning, and that's especially with the radiopaque streams, that is easier. Of course, what we want to not have is a severe patient prosthesis mismatch, which is fairly defined here. We need to understand, of course, with the balloon expandable valves, the risk of aortic valvular rupture. We need to understand the significant risk of paravalvular leak, and of course the other issues that exist. Of course, the reason for coronary occlusion is well understood here, of course, is a capacious sinus. And when this is a valve which is implanted, the leaflet is outside, the leaflet opens up and a new valve is implanted. And of course, if the sinuses are narrow, the leaflets which are long in a bioprosthetic valve are going to actually come up against, as a new valve is implanted inside it, are going to come up against and really create a curtain in front of the ostia. And that, of course, is the reason why the basilica procedures we just discussed by Dr. Singh-Tubal is talked about, is that if the leaflet comes up, if you've previously torn the leaflet by a technique that we would just be talking about, then you still expose the orifice of the coronary ostia to the flow, and it's not the curtain doesn't fall across the ostias. So therefore, it's a number of the anatomical factors. These are low-lying ostias. So it's not just low-lying ostias, but of course, narrow sinotubular junction. If there's no space, if the sinus height is low, that's when you create the curtain. If you have narrow sinuses, you again have a higher chance of creating the curtain in front of the ostias. Of course, there are the factors. The supraannular position has a lesser chance. The supraannular position has greater chances of giving you less patient prosthetic mismatch, but can actually create a bigger curtain. So one's got to be careful about that. High leaflet profile, internal stent frames, of course, and a variety of other factors which we need to understand and know about. But clearly, this is 2 to 6 times more common with the bioprosthetic valve. Okay, the tips. It's been said that one should actually just, let me just see if how much time do I have? I think I have 3 minutes still to go. So it's been said that you can actually size, you can know whether the coronary artery is going to be obstructed by pre-dilating the valve with the size of a balloon, which is supposed to be the size of the valve you're going to implant inside. This is one of the tips, but it clearly has its advantages, and I won't recommend it. It has a significant risk of tearing degenerated bioprosthetic leaflets, and this has clearly been described in this. One of our experiences was a 66-year-old lady who had a 21 millimeter perimount bioprosthetic heart valve. Well, we pre-dilated and we undersized it. We pre-dilated it only because it was high grade 0.2 aortic valve orifice. And the lady who had previously had syncopal attacks and had been in failure. So we pre-dilated with a 16, which was clearly undersized. And immediately she went into she lost her pressures. Well, we thought it was perhaps just the fact that you're going to get her pressures up. But of course, she just continued to deteriorate. And soon she went into ventricular fibrillation. It was a ventricular tachycardia and fibrillation storm, numerous shocks. Couldn't get her out of it. She was absolutely gone within 30 seconds into the storm. So you actually, therefore, of course, we got our resuscitation very ready at that time. So within 7 minutes, I think we had her, we ECMO, continued to shock her, wouldn't come out of it. Of course, we weren't sure whether it was the coronary ostia which had gone. So off we went. Of course, we could not see much because, of course, when the heart's not functioning, there's very little you can see about the cause of it. So we moved on. We realized it would be aortic regurgitation to survive, to make patients survive. You really need to put the valve in. So while we had a ECMO dysfunction, so we put the valve straight away in and on a cardiac massage. And we, of course, realized that this was aortic regurgitation. And then gradually over the next 30 minutes of a cardiac arrest, she actually started recovering. EVF form storm stopped. The LV was done. There was poor contractility. These were her pressures, as you can see. She was taken to the recovery unit. We had an injection somewhere here which showed us that the coronary was patent. And of course, the next challenge was, of course, that hyperperfusion, stunned heart. We had an antegrade perfusion. And so once the first 24 hours passed, she just recovered and went home happily a week later. So we've just said very clearly, never dilate these degenerated leaflets. It's not worth taking those. And then just briefly, the rules about positioning. Yeah, we have to understand that there's a new annulus. We need to position the valve just below that new annulus. The new annulus is to be the reference plane. It's the narrowest portion of the surgical valves in relationship to the sewing ring and should be used for the reference level. We can understand all this. I think this is it. VTC distance, that's perhaps the most important thing. We always judge that on the CT scan. The VTC distance is a virtual ring to the coronary ostia distance. And we can understand that the surgical valves may not be maybe tilted on one side, and therefore it's just because you got enough sinus space on either side doesn't necessarily mean that you're actually not going to obstruct coronary ostias, because you can actually have a tilted valve that's a raised position. So high risk, that's why the VTC distance is very important. The high risk is less than 3 millimeters, moderate risk is 3 to 6 millimeters. And then you have low risk of coronary obstruction if you're more than 6 millimeters. Always measure that. And if you really want to protect, you have to do a complete protection. For example, this is a Carpentier Edwards Magna valve. The patient was shot, had all these symptoms. And the VTC distance in this case was the low coronaries as well as low VTC distance. The coronary height was 7.1 on one side, it was 9.2 on the other side. That's right, it was 6.5, the left main was 6.5, and the right coronary artery was 9.1. And the VTC distance was around 4. And therefore that on the left side, and that actually meant that we needed to protect the left main. It was 5 on the one side. So we needed to protect this left main. And when you do a protection, it's low. So she also had a graft disease, so we just stented it also at the same time. But when you go to protect, you got to protect completely. So there's no halfway protection in these issues. The way we do it is very clear. We use a guiding catheter and then a guide liner. That's the one which always stays in. Then you've got a support wire inside, and we've got a stent inside. You just don't do a wire-based protection, because if you're going to get a stent in, you may never get a stent in the time the occlusion occurs. And so we have the works. The guiding catheter is well brought out. Only the soft guidezilla sits into the left main ostia, because when the valve opens up, it just impinges and pushes the guiding catheter in, can cause left main trauma. So guiding catheter stays out, as can be seen here. And then of course, this is after 10-15 minutes of watching. You've implanted that just 2-3 millimeters. This is a 1-2 view, by the way. 1-2 view will give you the best view of the left coronary ostia. This is a perpendicular view. The 1-2 view means 2 posts are upon each other. And the surgeons always place the ostia very, very neatly between the 2 posts. And of course, after you've viewed this for some time, then you're ready to actually take it out. Nothing more to talk about apart from 2 important aspects. The basilica procedure, which was talked about, which was discussed. It's actually a difficult procedure to perform, not easy. And of course, because it hasn't yet got dedicated instruments for it, the dedicated instruments are being brought out. And if once the dedicated instruments out, it perhaps maybe some of the life-saving procedures for some of these patients to tear the valve. Actually, what one uses is just a wire, which is electrocautery. It goes through the base of the leaflet into the left ventricle. Then you actually just put a snare in the left ventricle, withdraw the wire out, and then through the body of the wire, you just actually you just lacerate the leaflet, and therefore it doesn't obstruct the left main anymore. And that's what this demonstrates. So we won't go through the basilica. We are just one more thing I want to tell you about, that the patient prosthetic mismatch. Most of the valves used, a lot of valves used in India are 19 to 21 millimeters. They can have a patient prosthetic mismatch. I'll show you one of the cases, of course, where the patient mismatch had to be taken care of by true balloon. You always use a millimeter higher balloon than the valve itself. Always, when one prefers to do it, I would prefer to do it within the implanted valve, rather than just first do it and then put a valve in. So it's better to do it within the valve. And of course, it's got to be important that it's no more than 1 millimeter of the valve size. I think we won't just go through much apart from the take-home message that it's valve-in-valve is the safe and effective option at the moment for failed bioprosthetic surgical valves. It's critical to plan the case properly. Get the information. Complete information is important. Understand the sizing of the valves correctly. Always, of course, CT helps a great deal. Positioning is very important. Fluoroscopy is essential. 1-2 position helps us to do better. And of course, safety of the coronaries, as well as taking care of the patient prosthetic mismatch, will give us the best possible long-term results in these valve-in-valve situations. Thank you very much for your attention.
Nice presentation, Ashok. I think one question, why not, it's very difficult to predict which coronary will get occluded in valve, and as you told, why not protecting always all the cases in left main at least, while doing the valve-in-valve position.
If the sinuses, no, I don't think that's true. If you've got high coronaries, but you've also got high sinuses and large and high sinuses, you won't occlude it. So the VTC distance is the most important thing, of course, keeping that in mind, because that's what tells you about the sinuses. And the second aspect is the height of the sinuses. So you don't have to protect. In fact, you'll find that 20% of the times, 20% of the times you may protect, and still the coronaries won't occlude. They occlude in less than 5% or less than 2% of the times. So I think, yes, in doubtful cases, by the way, in borderline cases, do it, because it helps you to do more and more coronary protection so that when you need it, you're good at it. And we often do coronary protection for the sake of the fact that if it's half an indication, I'd rather do it and continue to be good at it rather than leave it for the real time when you actually absolutely need it. And that's the first time you're doing your coronary protection.
I think
so do you have any particular preference for a type of valve, self-expanding versus balloon?
Oh, yes. Yes, I certainly have that. Certainly, I actually believe that the supraannular, especially in the 19 and 21 millimeter, gives us the least patient prosthetic mismatch. Remember, it's already a bad job done by our surgeon. A 21 millimeter valve is actually an internal diameter of 18.5 to 19. And you can imagine that if you put another balloon expandable valve into it, you hardly leave any RFS. What you need is, one can actually, with a supraannular valve, and basically coming to evolute R itself, will get you single digit gradients in these situations. The moment you have more than a 20 millimeter gradient, it means that you have to be ready to fracture the valve, because those are associated with poor long-term outcomes, and you haven't done your patient justice.
I was referring to little borderline coronary heights, sir. Which is the valve of your choice? Valve-in-valve, obviously.
Right. So yeah, the borderline coronary heights, I mean, I would have showed you another one. I agree. That's the time when I start thinking, of course, if it is a large valve, that's the time I start thinking of a balloon expandable valve, because it also gives you the ability to access those coronaries far more easily if a situation arose of accessing them subsequently. So yes, provided the initial valve was greater than a 23 millimeter sized valve.
Okay.
You have to keep that in mind. Otherwise, the patient process mismatch is the worst outcome for a patient.
I think we'll move on for the next presentation by Praveen Chandra.